Thank you, Chairperson, sir, and good afternoon, everybody. Welcome to our international audience from Nepal, from Bangladesh, Maldives, India, and of course, home team Sri Lanka. Now, there is this saying in English, to have your cake and to eat it too. Is this realistic? Is it surrealistic? Is it being ambitious? Is it just voicing out something that everyone wants? I would also want to have my cake and yet eat it too. I would want to be able to spend a lot of money and yet not have my bank balance go down into the red. Similarly, our patients who come in, those who come in with diabetes, their request, their demand, their hope is that I want to have my insulin, but I don't want to have it also. I want to have good glucose control, but I don't want to be bound down by your rules and regulations, by your diktats, your do's, your don'ts. So therefore, we always try to search for the middle path. Now, this middle path, is it something new? Is it something related to diabetes care? Of course not. The middle path was taught to us by Lord Buddha. And what Lord Buddha said was, you try to aim for the middle path, the path of moderation. Don't go in too much of extremes. Suppose I tell my patient, I will give you 5 injections of insulin a day, and you will get excellent glucose control. We promise that you will not get any diabetes-related complications. That may be true theoretically, but practically, I'm keeping my patient tied down, bound down to 5 injections a day. That is not the middle path. On the other hand, if I tell my patient, oh, doesn't matter, let's enjoy, let's make merry, no need to take insulin at all. And life is short, let's enjoy life as it comes. Let's be happy and healthy today. The WHO definition of health says you have to be healthy today, that is physical, social, mental, emotional well-being. That is also not correct because the WHO forgets to add the word sustainable health, sustained health. So without insulin, we may be happy today, tomorrow, day after, but we are certainly not going to be happy a few years down the line. And that same person is going to come back and argue with us. Madam, when did I say that I don't want to take insulin? You are the one who didn't tell me properly to take insulin. So madam, it is your fault. So this is what the middle path means, the law of moderation. Don't become too aggressive with the patient. Don't intrude too much into the patient's life. At the same time, don't become too lax. Make sure that your patient follows a middle path. That's why we are trying to change the insulin experience. So over the next 15 to 20 minutes, let's see whether we are over-ambitious or we are realistic with this concept. Now, like our chairperson said, insulin is 100 years old. There is a lot of midlife maturity with insulin. Maturity does come in 100 years of existence. But apart from that midlife maturity, there is still maiden charm. Insulin continues to exude maiden charm the way a young man or woman, a boy or girl, any youth would do. There is something special about youth. That's why coming to Sri Lanka makes me happy. I feel younger being in the company of such beautiful ladies. The Nepalese ladies also. And that is why my chairperson, sir, he specially chose this topic to chair. So this maiden charm is there because we keep on learning about new insulin regimens, new insulin preparations, and new insulin delivery devices. Why are these words important? Insulin regimen, preparation, delivery device. The reason is that this is the hierarchy of decision making. When you're in practice as a physician, sometimes we go to CMEs. The CME is product driven. And so we tend to think of a particular product or a particular delivery device first. Then we end up making mistakes. When there's a patient sitting in front of you, the first decision you have to make is, does my patient need insulin or not? If it's yes, then you begin speaking with the patient about that. Start the conversation. Then you decide the insulin regimen. What kind of a regimen does my patient need? Then you move on to deciding about the preparation. And finally, you decide the delivery device. If we follow that order, we are not going to make mistakes. So let's look at regimens. Now, when you read the Western guidelines, they talk to us about basal insulins alone as the only regimen for initiation. But when you look at Southern and Southeast Asian guidelines, we are more democratic, more open to diversity, because maybe we have more diverse patients, more diverse patient groups. So we have different types of insulin regimens that we can use for initiation. We can use basal insulin. This we will use if your patient wants a simple once daily injection or if your patient has predominant fasting hypoglycemia. You can also use basal insulin in different ways. Look at the various basal-based regimens we have. Basal insulin monotherapy, just a basal insulin, once a day, no metformin, no sulfonylurea, because the patient is not able to tolerate them, or perhaps because they are contraindicated. Maybe somebody with CKD, somebody in the terminal stages of life. You can also use basal insulin plus metformin, basal insulin plus sulfonylurea, that's known as BIDS, BIDS, bedtime insulin, daytime sulfonylurea. You can use basal insulin with any other oral glucose-lowering drug. You can also use it along with GLP-1 receptor agonists. In fact, now they have fixed dose combinations. Actually, the correct word would not be fixed dose. It would be fixed ratio. We have fixed ratio combinations of basal insulin and GLP-1 RA. For example, we have degludec and liraglutide mixed in the same pen, in the same delivery devices. So even in basal insulin preparations, there is a lot of heterogeneity. And there's a lot of heterogeneity in the regimens as well. Basal-based insulins, they can be basal. They can be basal plus. Basal plus 1 would mean basal plus 1 prandial. Basal plus 2 would be basal plus 2 prandial insulins. And of course, basal bolus, which is the ideal regimen, which we use in type 1 diabetes, in pancreatic diabetes, that is basal plus 3 injections, 3 prandial injections. Now we just said that if your patient wants a simple injection, once daily injection, then you go for basal. But look at all this classification from a person-centered point of view. As a person living with diabetes, I am least bothered about whether you prescribe me premixed or basal, 50-50, 25-75. For me, the classification of insulin is 1 injection per day, 2 per day, 3 per day, 4 per day, 7 per day. It is a number-based classification. So you can also give premixed insulin once daily, which can be human premixed insulin. It can be biphasic aspart or biphasic lispromix, or it can be a co-formulation of idegasp. You can give premix once daily. You can also give twice daily. Some people use thrice daily. And of course, if none of these work, then you have to go to basal bolus. Now, let me talk about why all these regimens are present and why there is a discrepancy between our thought process and that of the West. In the West, in an ideal scenario, diabetes is a chronic disease. So you will find that the person with diabetes enters the healthcare system on day 1 of disease, continues with the same healthcare system throughout life. The healthcare provider may change. And as you continue in life, the trajectory is such that you are going to age, the beta cells are going to age, insulin resistance will remain the same almost throughout, almost the same, minor ups and downs. And because the beta cell continues to age, it gets tired, you will need more and more insulin. So they say, let's begin with basal, and we escalate or we intensify gradually. For those of us working in South Asia, whichever country we are in, we have to wear 2 hats, 2 turbans at the same time. Half of our patients are chronic. They come into the OPD with concerns. The only concern is an HbA1c of 7.8. It might be a CRP of 7, maybe an ESR of 28. I've completed 25 years in practice now. I still have not learned how to fix up this particular concern, an ESR of 28 in my patients. Maybe Dr. Rakesh Sai will teach us. So in a chronic setting, the patient will come to you with concerns. Very rarely they will come in with complaints. The complaints will usually not be life-threatening, limb-threatening, or organ-threatening. They are minor kind of complaints. So you are doing, like, the pediatrics people, they do well baby clinic, so you're doing a well diabetes clinic. This is in a developed setting. But in our setting, some patients come like that. Other patients come in with diabetes as an acute disease. So they will have symptoms. They will have signs. They will have comorbid conditions. They will have complications. They may be using a concomitant therapy, which is putting us in trouble. So there will be complaints, concerns, of course. There will be comorbid conditions, complications, concomitant medications, which need to be resolved. Then you have to work like an acute care physician. If as an acute care physician, you begin going slow. Today I'll give you basal. After 3 months, I'm going to give you basal plus. I won't escalate before that. Then you've lost the bus. We lose the patient. The patient loses trust in us. The patient goes and finds another doctor. And more often than not now, you see our patients going and finding alternative care practitioners. So if there is one message I would like to share, especially with the younger doctors, that is that when your patient comes into you, first of all, the triage you should do is my patient coming in for chronic care? Is my patient coming in for maybe subacute care, something in the middle, or maybe acute care? If you are a successful physician, your patients will come in for all of the above. Because you are successful, you are good at your work. And being good at your work, all that you need to do is to do the triage. Once you do the triage, if the patient is coming in for chronic work, then you listen to and you read all the guidelines. But if your patient is in an acute care setting, then usually the guidelines are not going to work. Then you go to SLC, you ask the senior endocrinologist of the country, what do I do? And they will tell you what is to be done. So with this background now, let us move on to the fact that we are assuming that most of our patients now are coming in the chronic care setup. In chronic setup, when you prescribe insulin, we begin with basal insulin. Different types of basal insulins are there. Initially, there was no basal insulin. NPH was created only around World War II. Neutral protamine hagedon. There's a quiz tomorrow. One question might be, what is the pH of neutral protamine hagedon? Which is the protein? The name of the protein begins with P. It's a powerful protein. Which protein is present in neutral protamine hagedon? What is the name of the scientist? He was not very happy. He was supposed to be a very grouchy, grumpy kind of a scientist, but he created NPH for us. Even though he was not happy, his name begins with H. So neutral protamine hagedon, which scientist created this? He was from Denmark, and protamine came from salmon, from fish, from the sperm of salmon fish. Now it is created chemically by recombinant therapy. We then moved on to analogs, glargine U100 and detamir. And then to the second generation analogs, glargine U300 and degludec. These are ultra long acting. Many other quiz questions can be there. And if you look carefully at this slide, you see that human insulin has got 51 amino acids, so does detamir. Glargine has got 53 amino acids, while degludec has got 50. So when you see this, you see that they are tinkering now with the chemical structure of insulin. And by various methods of acting upon the insulin molecule, they are able to prolong its action. So you can add a basic protein like protamine. You can reduce solubility at physiological pH. You can make the insulin acidic, like in glargine. So then microprecipitates form in the subcutaneous tissue. You can acylate. You can add a carbon chain to insulin, and then you will create detamir, degludec, and also icodec, which we are going to speak about now. You can also create fusion technology. Let me spend a minute on this. Now, when you look at Sinhala history, when you look at the temples, where do you find fusion technology? Let's give a hint. And so somebody already knows whose question that's going to be asked. So this animal, makar in Hindi, and maybe makara in Sinhala, I'm not sure, that is a fusion animal. Half mammal, half fish. What does that signify? A chimeric animal, chimera. Any volunteers? Manilka? So it's, I may be pronouncing it wrong. I apologize for that. But makar or makara is the dragon in Sinhala. What would be the correct pronunciation, please? Makara, okay. So that is dragon. And when you see the picture of the dragon, that is half mammal, half fish. That is a chimera, two animals fused together. So that was fusion technology. What does fusion technology give us? The makar is a sign of prosperity. It is also a sign of safety. That is why it guards our temples. And you trust the makar to guard your temples. So similarly, you can use fusion technology to create fusion proteins. The fusion protein can be used to prolong the half-life of any hormone. Example, erythropoietin. Example, interferon. And also example, insulin. So fusion technology is being used to create longer-acting insulins. We actually have longer-acting GLP-1 receptor agonists in the market. Dulaglutide is an example. So dulaglutide would be a Makara kind of a GLP-1 RA or a recombinant fusion kind of a GLP-1 RA. So these are the various things that we have spoken about, but let's move on to what's coming in the future. Like we said, once weekly GLP-1 RA are available. Dulaglutide is available in the market, and semaglutide will be available shortly. Once weekly insulins are also under development. So how have they created once weekly injections? Some companies, some pharmaceutical researchers, they got inspiration from our temples, from the Buddhist temples. So they used the Makara technology to create a fusion protein with insulin. Others have added carbon, because there is so much of talk going on about global warming, carbon imprint, carbon balance, and carbon load. So they decided to shift some of the carbon to the insulin. So they have put they began with C14, 14 chain. Now they've gone up to C20. They are becoming more and more ambitious. So they have added long chains, C18, C20, to make the insulins longer. Other companies have learnt about square pegs and round holes. So they have created pegylation. That is another way of changing a protein, polyethylene glycol. They added that, and some of them created microspheres, small bubbles. So all these different ways of prolonging action are there. Insulin, Sphtora alpha, this is the fusion protein that we speak about. They have the alpha chain, they have the beta chain. They have analogs of these, and both the chains are mixed to a fusion protein. They are added to a fusion protein. There's a fusion protein in the middle. So this is one way in which once weekly insulins are being created. But out of all the insulins that are there, the one that has reached furthest, the one that has completed phase 3 trials is ICODEC, ICODEC. There are 3 amino acid substitutions here, which increase the stability of the molecule, which prevent it from getting degraded or cleared. And also, the last amino acid of the B chain is removed. So from 51, we go to 50 amino acids. Out of those 50, 3 are changed. And they have added a C20 chain, carbon 20. Like I said, the pharmaceutical developers have become better and better. They started with C14, then 18, now they moved to 20. And when you add this diacid chain, it also makes the molecule bigger. The molecule becomes bigger. The molecular weight goes up to 6400 Dalton. What impact does this have? When you inject a small molecular weight, a small molecule into the subcutaneous tissue, usually it is taken up by the capillaries. If you have a middle-sized molecule, it will be taken up by the capillaries and the lymphatics. But if you have a molecule which is weighing 6000 Dalton, that will be taken up only by the lymphatics. So the lymphatics are a bit lazy. So just remember L for lymphatics, L for lazy. So there's a lazy kind of an uptake. So you are able to prolong the action. C20, when this allows us to prolong the action, what I am reminded of is Sri Lankan cuisine, the Sri Lankan spices, the cardamom, the cinnamon. This is something that anybody from North India would die for. When we get the cinnamon from Sri Lanka and we take it home, actually you cannot imagine what kind of happiness goes through the home. You know, the fragrance is something different. So this is a kind of fragrance. Maybe the ICODEC developers also got their inspiration. They would have come to Sri Lanka sometimes and tasted our cuisine. And same is true for cardamom. And on a separate note, my wife loves the cardamom from here. And the kind of cardamom and cinnamon we get in northern India, that is, it's like, you know, very marasmic kind of. Actually, you will feel marasmus is the only thing that will come to your mind when you see our spices. So coming back to ICODEC, and Chairperson sir is also staring at me like, so sorry sir. So ICODEC, when you put into the subcutaneous tissue, first of all, what happens, the hexamers get broken down into monomers. There is a very high density injection volume. It is 700 unit per ml. While with the routine insulins, it is 40 unit or 100 unit per ml. So because it is very concentrated, it will take more time to disperse. The hexamers get broken into monomers, and then they bind to albumin. Now there's lots and lots of albumin in the body. Roughly 5 grams per deciliter, which becomes roughly 50 grams per liter. And if you are weighing 70 kg, then that means you have 7 liters of blood. Sorry, if you are weighing 100 kg, that means you have 7 liters of blood, roughly. So if you are weighing something like 70, 75 kg, that is 5 liters of blood. So 5 grams per deciliter, which becomes 50 grams per liter. 50 grams into 5, that is 250 grams. There's a lot of albumin in the blood. So albumin is not like a Goldilocks kind of a hormone. Goldilocks hormone means very low therapeutic index, very, very narrow therapeutic index, very narrow physiologic index. Supposing I were to give rapid acting insulin, if I give 6 units instead of 4, or I give 2 units instead of 4, my patient can land up in hypoglycemia or hyperglycemia. So this is a Goldilocks kind of a drug. Same for digoxin, same for warfarin. Goldilocks hormone, why we call it? Because when Goldilocks went into the forest, she went into this house where there were 3 beds, 3 rooms, 3 tables. So some were too big, some were too small, some were just right. So you have to find the just right space for rapid-acting insulin, digoxin, warfarin. Narrow physiologic index, narrow therapeutic index. But icodec is a very safe kind of a drug. It's a very happy and relaxed kind of a drug, a very wide physiologic index, because albumin is so much in the body. 250 grams of albumin will never finish. So if your patient has got renal impairment, hepatic impairment, maybe portal hypertension, maybe your patient is actually marasmic, has got protein deficiency, even then the drug will act safely, because that much albumin is there in the human body. So this icodec goes in as monomers, gets bound to the albumin, and then gradually it begins getting released from the albumin, very slowly. And why gradually? You just remember the spices that we use. The spices are meant in such a way that they keep on titillating your taste buds slowly, slowly. So if you have something tasty for breakfast, you will remember it even up till lunch. So that kind of work is done. But icodec builds up slowly. So supposing someone were to come from maybe Nepal to Sri Lanka, the first time they eat that sambol and mini sambol, then it hits. So that's not nice. So what the icodec people did, they built up slowly. There's this warm-up phase going on. So warm-up means that the clearance is very slow. It takes 4 to 5 weeks for the drug to reach steady state. After 5 injections, that is after 5 weeks, everybody is at steady state. So it builds up slowly so that there is no chance of hypoglycemia initially. And also, there is no chance of side effect initially. This is one point. Second point is that some doctors, what they do is, you can give double the dose, the first dose, to hasten the onset of action. So the first week, you will give double dose. Second week, you go back to normal dose. How do you calculate the dose? Supposing you want to give 20 units of basal insulin, or patient is already on 20 units of glargine. You just do 20 by 7, 20 multiplied by 7, 140. So you give 140 units every week. But first week, you can give 280 if you want, double. That is one option. If, however, your patient is on twice daily basal, maybe 10 units twice a day, or on glargine U300, then you will reduce the dose by 20%. So maybe my patient was on 10 units of glargine U300. I reduced by 20%, that becomes 8. So 8 into 7 is, now that is a very difficult question. No? 56 is correct, sir. So 56 units you will give. And the other beauty is that the half-life is 196 hours. That it is 7 days. That is the half-life. The other beauty is that after the first day, throughout the week there is equal exposure to the insulin, and there is equal impact on glucose lowering. So it's not that there is a lot of impact in the first 3 days and no impact in the last 7 days. So there is smooth control throughout 1 week. The name of the research program is Onwards. So there are different Onwards trials, all of which show that you are able to bring down the HbA1c successfully. You are able to achieve better HbA1c control in a more number of patients without causing hypoglycemia. So very safe drug to use. And apart from that, the greater convenience, better adherence, quality of life, patient feels in charge of his or her life. You can tell the patient, madam, I think you need 1 or 2 drugs a day. And then you look at the patient's body language. If patient says, yeah, I'm fine taking 4 drugs a day, I don't mind. Then you say, but madam, since you are so enthusiastic, you are so much concerned about your care, why don't we try only 1 injection a week? Let us see what happens. That gives a feeling of democracy, feeling of being in charge to the patient. On the other hand, if you advised 1 or 2 injections a day and you see the patient stepping back, madam, I am going to leave you, I will go and find another doctor if you utter another word about insulin. Then you say, okay, we have another option. This is once a week. Why don't you think of that? So both ways, you can talk to the patient about this. And the advantage is that you have another option to share with your patient now. How will we use this in practice? Just 3-4 slides left. I think post-lunch is the wrong time to speak about Sri Lankan spices. But we will use it as a basal insulin. Remember that once weekly insulin, Icodec, is not a substitute for premix. It is not a substitute for basal bolus. It is a substitute for basal insulins. Now, when you have anything new, it is a good idea to do a SWOT analysis. SWOT analysis means strengths, weaknesses, opportunities, and threats. So what are the weaknesses? Initially, why did we speak about acute diabetes versus subacute versus chronic? Because this is not going to work in acute settings, where you need immediate resolution of hyperglycemia. First, you fix up the acute or subacute issue that the patient has come with. When the patient is stable, then we can introduce this. That's a limitation. Secondly, you will need regular meals and lifestyle. You can't say that I'm going to fast for 3 days and then I'm going to go binge eating for 4 days. Then this drug is not going to work. And you will need prandial coverage. Whether you take that prandial coverage through tablets or through insulins, that is separate matter. But you will need a separate drug for prandial coverage. What are the opportunities? This was the limitations. Opportunities are that now lots of changes are occurring. When you look at vitamin D, cabergoline, alendronate, GLP-1RA, once weekly administration is becoming more and more common. Even antibiotics. Earlier we would give amoxicillin 4 times a day. Now we use once daily antibiotics. So things are becoming easier for our patients. Similarly here, you can use this. There's an opportunity. You can use it with other once weekly drugs. Somebody might be requiring alendronate or vitamin D. Another person might be requiring GLP-1RA. So you can mix with that. You can give it at the same time. That's an opportunity that we have. Another opportunity is for patients who have who don't want too aggressive control. Maybe somebody with the renal impairment, hepatic impairment, somebody at the terminal end of life, somebody who requires only palliative care. This would be a good drug to use. You are able to offer palliation, reasonably good amount of control. What are the threats? We have spoken of weaknesses, opportunities, but the threats. This is certainly not a panacea. Like we said, it is not going to replace premixed or basal bolus. And it is not to be used in type 1 diabetes, pancreatic diabetes, or in pregnancy. It is to be used only in type 2 diabetes as of now. Studies will come for type 1 diabetes, but that is for the future. We have spoken of weaknesses, opportunities, and threats, but we forgot to talk about strengths. So let us conclude with this slide. Let us conclude with a statement of strength. This new once weekly insulin is actually very easy to use, more convenient. It allows independence to our patient. And there is a concept known as index of intrusion. The more aggressive you are in practice, in drugs, in diagnostics, the more you are intruding into your patient's lifestyle. Patients don't want that. They want to be independent. This is a nice way where you can show independence. Just 1 injection a week is all that is needed. The rest you continue with whatever you're doing. Some patients may say, I am not confident of taking the insulin myself. So DOT, directly observed therapy, which we have in tuberculosis as well. Tuberculosis is nearly eradicated thanks to this. You can do a DOT. The healthcare provider can inject the insulin once a week. Or even if it's not a healthcare provider, elderly lady living in the village alone, but the son comes every weekend to meet his mother. So when the son comes, that time you can inject. Let him inject for you. Another advantage is thermostability, something very important for South Asia. So the label shows that it can be used as at room temperature. It can be stored at room temperature in continental USA. Now the fun fact is that continental USA seems to have hotter temperatures than we do. At least that is what has happened last month. So if they can keep this at their room temperature in Texas and in New Mexico, then we can also keep it. So that is a huge advantage for us. You don't need a cold chain. And the question was, are we overambitious? But then I realized this is the 20th anniversary of my first visit to Sri Lanka. I came here first in 2003. So thank you, everyone. And I keep on coming back again. And it is not just the cuisine, and it is not just the makaras on the Buddhist temples which call me. It is the fellowship, the friendliness which calls me. I am grateful for that. Thank you. It is also the 9th anniversary of this article that we wrote. We wrote it in the Australian Journal of Rural Health. It was directly observed therapy in diabetes. Current thought, future reality. I did not know at that time that that reality will come so fast. So this is something that we wrote nearly 10 years ago. So I would say that my topic for today was, are we overambitious? I would say that we are not. We are not overambitious. We are just being realistic. We are being pragmatic. And once weekly insulin will very soon change the way in which we manage diabetes. Thank you.